spotlight just for you.
Oh my goodness.
All right, good morning, good morning. I hope everyone has had a chance to get some tea, some coffee, to reach across the table, across the aisle, and greet the person that you've been looking for this opportunity to network with and speak with. I want to welcome everyone back. We're very excited for this next discussion as we sort of progress through the journey, the life cycle, from birth to adulthood, thinking about how health and wellness impacts the community. My name is Kameron Van Patterson. I'm very, very honored to be here this morning and to share and learn a lot from this conversation that we're having. It's obviously a very, very important conversation for us to have, especially at this time in our nation, and I'm excited to be here. I have the honor of serving as the director of the Judge Alexander Williams Jr. Center for Education, Justice, and Ethics at the University of Maryland. And one of the key issues that we're looking at broadly is public health and wellness. And so having this chance to speak with you and join in this conversation this morning is very appropriate. And I'm looking forward to it. I want to, well, before I introduce our dynamic panel, I want to express gratitude and thank you and appreciation to the National Minority Quality Forum for sponsoring this event in cooperation with Congresswoman Kelly and the Congressional Black Caucus Health Braintrust. That's right, give it up. It takes a lot of effort, as you know, to bring people together, especially in the day and time that we live in with 24-hour news cycle and such. And so it's just your being here and the sponsors coming together to coordinate and organize this means a lot. It's important that we create these spaces and these forums for discussion so that we can identify the challenges we face and then resolve them. I want to take a few minutes to briefly introduce this panel, and then I'll introduce our panelists, and then we'll dive in. We're going to have a robust conversation, and we will definitely look for your feedback and your comments and questions at the end of our panel discussion. So, as you can see from your program, looking at health equity from the womb to mature adulthood, we are here at the second panel, and this is particularly important for me as a new father. I learned a lot and was very intent to hear from the last panel. But I'm also, as an educator, I think about, as a high school educator, I've thought a lot about adolescents and where our youth receive the kind of support and access and wellness and wraparound services that they need to be successful. And we talk a lot in education about social and emotional learning, about having and adopting a holistic approach to the child. And so this panel is very important because I'm going to be talking about our kids and our future. I think anyone who has paid any attention to recent news has seen how the young people in Florida and Parkland are leading in a very powerful way. And it reminds me of SNCC and the way that we saw youth engaged during the civil rights movement. And so I think health is a moral issue, certainly is a civil rights issue. And so thinking about Generation Z, young people born between the mid-1990s and the mid-2000s, social media connects them and social causes mobilize them. Their health needs are as unique as their Instagram handles. This panel will emphasize the clinical and social investments being made or that need to be made to advance the health of children and adolescents well into adulthood. I would like to start by introducing Dr. Doris Browne, who serves as the president of the National Medical Association. Also joining us this morning, Ms. Jenne Johns, who serves as the director of health equity at AmeriHealth Caritas. We're also joined by Dr. Ankoor Shah, who's the attending pediatrician at Children's Health Center at the ARC, Mobile Health Programs, and Associate Medical Director for Advocacy and Innovation at Impact DC. Also joining us, we have Ms. Nicole Harrington, who is the Senior Director for Pharmacy Services at CVS Health. And last but certainly not least, we have Dr. Winifred Booker, who serves as the CEO and Director of Development for the Children's Oral Health Institute. So before I take my seat, I'm going to ask each of our panelists, and maybe Dr. Booker, we'll start with you. Since we had an occasion to speak a little bit yesterday, I shared with Dr. Booker that I've been working on my smile. And so we talked about the importance of dental care. And so I'm going to ask if each panelist can just take a few minutes to share with the audience your perspective or your view on sort of the issues surrounding youth, health, and education from your various perspectives. Dr. Booker.
Thank you. Good morning, everyone. I am a pediatric dentist. I graduated from Tennessee State University, and I'm a proud graduate of Meharry Medical College. My dean is actually here today. And I received my certificate in pediatric dentistry from the Children's National Medical Center, and I'm a board-certified pediatric dentist. I established the Children's Oral Health Institute in 1996 because I became frustrated about all of the disease I was seeing in children. And I realized that drilling and filling was not going to be the answer. And that so many of our children practicing in the inner city community where Freddie Gray and his two sisters were my patients as children, I realized that these children were raising themselves. They were in the mom and pop stores. They were buying their meals themselves. And many of those meals, included confectionaries that were causing some of the tooth decay that they had been introduced to by maybe the sip cup or the baby bottle. And so I established the Children's Oral Health Institute to come up with educational ways and programs to empower children to be able to better take care of their own oral health. I created programs like Lessons in a Lunchbox, Project Clean Toothbrush, Operation Healthy Holiday Stocking, ways to endear children and encourage them to pay attention to some of the dietary issues that were causing some of the health problems because I felt like I wasn't reaching the parents. I also created a toothbrush company to also help to create products that would also endear children and encourage them to be responsible for their own health because we see children in the inner city shopping and buying meals for themselves as early as 6 years old. And so I felt like if I could educate children about diet and health themselves, they would in turn share some of this information with their parents. And during the panel, I hope to tell you a little bit more about those programs. And so basically that's who I am, and I've been practicing for 30 years. I don't believe going to the operating room and putting stainless steel crowns on children's teeth are the answers, and so I look forward to engaging the panel more as well as the audience about some of the things that we've been doing in oral health to try to move this conversation forward and to empower communities and families to have better oral health. I think interproximal collaboration is going to be a big part of it, and I look forward to especially talking with our medical colleagues about that. Thank you.
Jones.
Good morning, everyone. My name is Jenne Johns, and I come before you this morning wearing two hats. My first hat is as Director of Health Equity at AmeriHealth Caritas, a national Medicaid managed care company headquartered in Philadelphia, where I was born and raised, in which we serve 4 to 5 million Medicaid, Medicare members on an annual basis across 9 states. And in my second hat and capacity that I come to you this morning, I am the mother of a micro-preemie and book author of Once Upon a Preemie, the only children's book written to motivate, encourage, and inspire preemie parents when they're bedside with their babies in the neonatal intensive care unit. I've spent the last 10 years of my career working in the health equity and health disparity space, advocating from issues ranging from childhood obesity prevention here in our nation's capital, obesity prevention and awareness for adults through education and philanthropy, cardiovascular disease and diabetes. I also have a master's degree in public health from Temple University with a focus on community health and health education. None of my career experiences, my advanced degree, nor my new income as Director of Health Equity at AmeriHealth Caritas prevented me from delivering my baby 14 weeks prematurely. And as a follow-up and segue to the last panel that we just discussed on infant mortality and maternal mortality rates, prematurity birth disparities are also a huge issue and glaring disparity in our country. 1 in every 10 babies are born prematurely in our country, and of that, half are born to African American women. Yet when we read the New York Times, the Washington Post, we look at social media streams, prematurity in the African American community does not receive as much attention as it should. And so as this panel is talking about raising healthy children, youth, and adolescents, if our mothers are going to survive delivery, if our babies are going to survive delivery, and then if they land in the NICU, we also have to make sure they survive and they have a healthy start and a healthy chance in life. And so I hope that part of our remarks this morning on this panel will continue the conversation about the needs of African American women's health and health outcomes from the womb and beyond. Thank you.
Thank you. Excellent. Thank you. Once Upon a Preemie, and is that a children's book, or is that aimed at an adult audience?
It's unique because I like to equate Once Upon a Preemie equivalent to The Goodnight Moon for preemie parents.
Okay, okay.
So the book is really written from a children's or a child's voice, the preemie baby's voice, to their parents to motivate and encourage and comfort the parents, because as you know, when a baby is born prematurely, the parents don't have the blessing or the unique opportunity to take their babies home from the NICU because the babies aren't healthy enough. They're connected to oxygen and feeding tubes and all sorts of medical equipment and devices to keep this child alive. And during my nearly 3-month stay in the NICU, there was no Goodnight Moon for me to read to my son. And so 1 month after coming home from the NICU and my process of healing and recovery, I wrote this book as a contribution back to the NICU and preemie space, because all preemie parents deserve this level of comfort.
Ashe. All right. I'll be going to pick it up. Dr. Shah.
Likewise, I think my clinic just has a new book on its shelf
right.
as well. Hello, everyone. My name is Dr. Ankoor Shah. I'm a pediatrician. I care for kids every day right here in the district. I'm part of the Children's National Health System, the largest pediatric provider in DC. And I also help lead our childhood asthma clinic here in the district. And actually, I want to talk to you a little bit about DC and health in DC specifically, because I know we have some people that are visiting from out of town, and I think the district is a microcosm of what's happening in the United States, specifically in terms of health disparities. So we are currently in the west end of the city in this nice hotel. On the other end, the east end, is another part of the city that is just as vibrant, just as exciting, and has a rich culture, but also has significant barriers. And that's where our clinic is. That's where a lot of Children's National resources are, specifically in Wards 7 and 8. So this is an area in which DC in general is very small geographically, but in a 4-mile distance, we see infant mortality rates that are 20 times more in Southeast DC in Wards 7 and 8 than up in the Northwest counterparts. A lot of health disparity as well. So for childhood asthma ED visit rates are 20 times more in Wards 7 and 8 than in Northwest DC, infant mortality as well. And this is actually due to structural causes as well. So for example, there's one hospital currently in Ward 7 and 8 that recently shut down their OB unit, so there's no place to deliver a baby now in Southeast DC. There's 2 grocery stores in this part of town, so we have a food desert as well. One grocery store serving 70,000 people, versus when you cross the river by the National Stadium in the other wards, there's about 4 or 5 within a couple mile radius. And there's also a higher incidence of community violence as well and housing instability. So the kids I see in my clinic are exposed to this environment. So how we actually treat our children and families can't be the same way. We have to think about, I always say I only have 15 or 30 minutes with a child. Well, what are they doing for the other 23 and a half hours of their day, and how can we affect that? And that's exactly what we try to do, especially at Children's National in our clinic. The place where I work, Town Hall Education Arts Recreation Center, has a girls' school, a boys' school, the Washington Ballet, a community garden. We have mobile medical and dental units that go out into the community. So transportation is not a barrier. And I look forward to talking to you a lot more about all the different innovative activities that we do to help mitigate these social determinants of health, help address some adverse child experiences so children can grow up strong. Thanks for having me.
Excellent. Thank you. Thank you so much.
Yes.
You referenced something about equity that I think would be good for us to come back to in terms of what that really means.
Yes.
Dr. Browne.
Good morning, and thank you for inviting me. I am Dr. Doris Browne, President of the National Medical Association, the oldest health professional organization for African American physicians and allied health programs. I thank you for being here today. One of the focus for the National Medical Association, of course, is that we are creating a collaborative approach to healthcare. It is called the National Action Plan for Health Equity. We have spoken about health disparities for far too many years, and the needle has not moved. And so my focus is to bring together organizations such as our dentists, our nurses, our community programs, industry, advocacy, and policy to bring about health equity. It's about us creating it for ourselves and making things change. And as I am not a pediatrician, I'm an oncologist, but we know that healthcare is a right, and we have to exercise that right. And so one of the things that I think is really important as we talk about adolescence is that we are raising a generation that's sicker and have a shorter lifespan than our parents. And it is time for us to then bring about those changes to make that generation grow up to be healthier, stronger, because really our children are our future.
Thank you so much. Yeah, we're definitely going to spend some time thinking about, both 2 panelists mentioned the need for collaboration across sectors. And so I think that's a really key point. Ms. Harrington.
Hi, I'm Nikki Harrington, and I'm Senior Director of Pharmacy Services at CVS Health. I'm really a pharmacist by trade. I've spent a lot of time being a community pharmacist, helping my local patients. But I've been lucky enough to be able to have an opportunity to be able to go into the corporate office and to design our impact across the retail book of business. And I think many of you, if you were to open the newspaper or turn on the news, every day you're hearing about the opioid epidemic and crisis that's facing our country. One of the things that I've taken a leadership role on is how do we get out into high schools to educate teens around prescription drug abuse. We developed a program in 2015 that allows our pharmacists to volunteer their time to get into local schools, to talk to them. They really have a unique perspective. They're well respected in the community, and they can really have an impact with these students. We have a 35-minute program in which we work to dispel the myth that prescription drugs are safer to abuse than street drugs. There's impactful videos to try to help get to the root cause of where students think about these drugs. We worked with a professor from Cornell to incorporate ways that teens think about risk and to really make sure that they're understanding the risks around prescription drugs. I'm pleased to say we've done 7,500 presentations and we've impacted over 350,000 students. We want to get into more schools, so I'm hoping that we'll have some conversation on how to access more students to be able to get them information. I have pharmacists clamoring to be able to get out and deliver this to students, but there's some barriers in being able to reach educators to get entry into those school systems. As part of building this program, we also realized a gap as we were talking to many kids that they had never talked to their parents about prescription drugs either. Their parents would oftentimes talk to them about alcohol, maybe marijuana, but prescription drugs was never part of the conversation. So we've also developed a program in which we go out and talk to parents and educate them about the things that they should say or equip them with answers that they may not have been prepared to answer. Kids are very savvy today and they understand drug culture much different than we do, and so preparing parents to be able to talk about things like legalization of marijuana and how to talk about some of the things that kids are experiencing in schools today is important. In the third generation of that program, we're actually working right now for launch in 2019, a program for our elderly population. These are patients that have been treated for a long time with prescription opioids, and sometimes they don't realize the dangers themselves of taking those medications long term, combining them with other medications, or even combining them with alcohol. So that's the triad of what we're working on from an education standpoint, and I'm hoping that we'll be able to engage in more conversation about that today.
Excellent, excellent. Thank you so much. Appreciate it. Ms. Harrington, I think you mentioned the opioid epidemic, and maybe that's a place to start in terms of thinking about how we educate young people about health, but also the use and or abuse of drugs. Can you share a little bit about, you mentioned, I think, the Pharmacist to Teach program. What has been, I guess, your take on the treatment of this epidemic in the media? And in your view, are we adopting the right approach to how we're framing this issue and talking about it? And I'm just going to say, I find a stark contrast between how drug abuse is being framed now compared to how it was being framed a decade, 20 years ago. And I think that has to do with a lot of things, but I'm wondering if you could offer some perspective on that issue, since it's something that's very relevant at the moment.
Yeah, and some may think that we may shy away from that media exposure, but I welcome it because the more that we get people talking about it, the better visibility people have in the community to be able to be open about substance use disorder and to break down the stigma. Because I think that the stigma presents barriers to people getting the right treatment and to moving on to recovery. So I think that, you know, all of the media exposure is a good thing for everybody.
Okay, excellent. All right. A number of you just mentioned the need for sort of cross-sector collaboration, and I think Dr. Browne, Dr. Shah, Dr. Booker all mentioned the importance of this, and I'm wondering for the entire panel really, but what does that look like? Where have you seen success in sort of brokering those kinds of relationships and creating those collaborative partnerships? I know, Dr. Browne, you talked about the initiative, the National Action Plan for Health Equity. And so give us, if you can, maybe a practical example or a method or an approach that's something that could be reproduced, and taken to scale.
Okay, well, starting this year in September at the Congressional Black Caucus Foundation, the National Medical Association held its first phase of the action plan, where we invited, and they all accepted, the Nursing Association, the Pharmacy Association, social workers, dentists, And we included the disease associations, such as heart disease, diabetes, those disease entities that impact our community in a greater point. And they all sat around the table and talked about working collaboratively on creating this action plan, because we should not continue to work in silos, because we're really talking about addressing the social determinants of health. And I should say the Public Health Association, the health executives were also part of the plan. And then we moved to the second phase of this at our health colloquium that we just held in March, where we brought together our policymakers, our social organization, and I sort of consider them our advocacy groups. So we had the faith-based organization, our Greek organizations, our 100 Black Men, the Links, et cetera. Because again, we looked at this whole program as it takes the entire village to bring about an action plan. And if we talk about social determinants, and we know that it's going to impact our community in a greater way, so wanting each of us to take a piece of this pie and say, what is it that you can do to really bring about change? And part of the colloquium, we talked about best practices and best models. And so we brought in the National Urban League and the NAACP to say, what programs have you done that's worked, and can we duplicate that in other communities across the country? And because the National Medical Association is national, we have 6 regions throughout the country, we can go back and duplicate that around the country to address all of those issues. And so that's where we're focusing on. And particularly, if you look at infant mortality, which is a marker of the health of a country, we if you look at wealthy countries, we are number 32 out of 35, which is terrible. This is an industrialized country, and we should do better. We have all of the knowledge and the technology. It is putting it to use instead of repeating the same things over and over again and not working together in a collaborative approach to bring about change.
Dr. Shah?
I think just looking at this panel, here in DC, we actually see some of this cross-sector and partnerships already. And let me give you an example. So childhood asthma is the most common chronic disease of childhood, and especially has a racial and socioeconomic disparities as well, and specifically with childhood asthma. It's also responsible for over 13 million missed school days annually. So what we decide in our asthma clinic is, well, is there a barrier to access to getting albuterol in schools? And there was, because it's hard for a parent to bring it in, fill out all this paperwork, et cetera. So we teamed up with, first of all, AmeriHealth, and said, well, how about we have the child have 2 albuterol inhalers, prior authorization for 2 albuterol inhalers. Our AmeriHealth, a Medicaid colleague, said, of course, that makes sense. Easy collaboration, it was done immediately. And then we went to our pharmacy colleagues and said, well, you know, it's difficult for a family that has a lot of things going on to actually remember to bring their albuterol inhaler to school and do that. And I know this, I can't even bring anything anywhere, so imagine a family that has a lot of other stressors going on. So they said, well, why don't we develop a program with FedEx in which we deliver the albuterol directly to school? So now I prescribe it directly to the pharmacy, and they deliver it to certain schools already we're piloting here in the district. So this is a perfect example of collaboration to think ahead to reduce barriers. Another example with AmeriHealth is transportation, a huge barrier to care. And most Medicaid managed care organizations have some sort of transportation service, but you have to call ahead, and the timing is sometimes off. But I get places using my phone, using Uber and Lyft. So AmeriHealth said, why can't we have our families do the same thing? So now we have Lyft for our families as well to urgently get to medical appointments as opposed to reconnecting to primary care as opposed to going to the emergency room and decreasing utilization in emergency room. So usage. So I think there's, just in using childhood asthma, an example in the district, a lot of cross-sector collaboration with payers as well as with pharmacy providers.
Excellent. Thank you.
So just
Thank
as
you.
a follow-on, since you're referencing my daytime job, AmeriHealth Caritas, in which we are heavily focused on reducing the burden of childhood asthma disparities for all of our children, but in particular our African American and Hispanic children. And we do have great multidisciplinary partnerships with organizations like the ARC, direct medical offices. So we've created programs across the country, not just in the District of Columbia, where if medication access is an issue for our parents with small children who have uncontrolled asthma, who are overutilizing the emergency room because they don't have a relationship with a primary care physician, forget a specialist, an allergist or a pulmonologist. If the relationship is not there between parent and primary care physician or pediatrician, the resources, the medication resources are in a locked box in the doctor's offices so that the physician can administer the medication with the parents and not have to take a trip to the pharmacy, which in some of our markets, like in South Carolina, where transportation is a really big issue, and there may not be a lift to get someone 10 or plus miles to the local pharmacy, the medication is administered there. In addition, as Director of Health Equity, I look at our health outcomes by race and ethnicity, written and spoken language, almost on a daily basis. And the disparities around asthma and asthma outcomes are glaring. They're alarming and they're extremely disheartening. And so to take this asthma conversation a step beyond the provider's office and what happens during the school day, which is a big disruption for children's ability to learn and to be healthy and to live and play in environments that are causing them harm, we instituted a program in which we are taking our community health educators and asthma educators into the homes of our children with asthma that's uncontrolled, and doing in-home environmental checks and scans, doing parent and child asthma education, as well as referring our parents and our children to the necessary non-clinical resources that they may need to help control their child's asthma. This program is showing phenomenal results within the walls of our organization, but also nationally. I hope that as we are thinking about what necessary programs, what necessary funding streams, what necessary legislation is needed to ensure that our children have the best possible start as children, youth, and adolescents to grow into adulthood, that an asthma home visitation program is considered. We are seeing the rates of the emergency room visits, utilization, and even inpatient stays reduced significantly just by having someone who can walk alongside the parents and child's hands to help them to better understand how to manage their child's asthma condition.
Thank you. I want to get a comment from Dr. Booker because she mentioned the need for interproximal collaboration as well, and then we'll circle back.
Okay.
I think that certainly interprofessional collaboration is going to improve the health of our children and youth. I serve on the Maryland Medicaid Advisory Committee, and one of the things that I had said to the committee is that we have HPV screening now. And when you have an 11-year-old that's diagnosed with HPV, simply because she says she's just kissing, and then you have a 17-year-old that has to have a jaw resection secondary to HPV, then interprofessional collaboration is important. We as dentists are going to screen for that, but then we're going to get that patient to our physician colleague. In the state of Maryland, they pay $5 for that screening, and many dentists don't invest in the fluorescent light to do the screening because it costs $2,000, and Maryland Medicaid is reimbursing at $5. So I said to the company, let's do a campaign, let's do a program. We talk about out of the box thinking and doing some creative things. 5 to stay alive. If that's what the state of Maryland pays, let's expose that. Let's do a 5 to stay alive campaign. They're paying $5 to reimburse for that. So the 17-year-old gets a jaw resection, the 11-year-old is diagnosed. Let's talk about lead paint poisoning. In Baltimore, we talked about Freddie Gray and his 2 sisters. We saw that unfold on television. He was lead paint poisoned, and so kids, we understand what happens to children that have lead paint poisoning. In Baltimore, in Washington, in New York, where we have our old cities, where we've come with lead paint poisoning is still tragic. Our numbers are really low. When we have only 20% of kids getting screened for lead paint poisoning, how do we educate parents? Whose spit is it? It's the dentist. And so now we have a screening test where, once again, we can refer to our physician colleagues. So they said, well, you can't do it. You can't do it. And I've been battling for this for 10 years, to allow dentists, interprofessional collaboration, to do lead paint poison screenings. Whose spit is it? It's our saliva. We see the patient more often than our physician colleagues, and we're not trying to diagnose, we're screening. And so we see the markers because now we have the Schneider test, we can refer to our patient. I mean, let's talk about even tooth decay. The American Dental Association asked me to represent organized dentistry on this panel today. I'm a member of the National Dental Association of the Society of American Indian Dentists. And so that they have a campaign called Snack All Day, Risk Decay. Even that, with this generation, how do we expand those campaigns to have them to take a look at it? Maryland says our pregnant women, only 20% of our pregnant women are utilizing the Medicaid resource while they're pregnant. But why is that? So they've created, again, another brochure, a pamphlet. And so we need to expand that program. And when I heard, when they gave the numbers, when they gave the dental report last month, I said, well, why is that? They said, well, we have the literature out, but there's no interprofessional collaboration with that. So I said, okay, how about this? Let's, on the side of our buses, we talk about Medicaid and the benefits we have. Let's put a pregnant tooth on the side of the bus. They said, a pregnant tooth, really? But is it a satire? Will it get attention? Will it bring our young people, our Generation Z that we're talking about, will it get their attention? And then we can give them all of the information about what can happen during pregnancy. There's other things. How about vaping? Now we got kids that are vaping, and the oral health outcomes from vaping, and they don't think that they're smoking. It's just like we have to educate Generation X or our middle school kids about oral sex. They don't think that oral sex is real sex. And then we're seeing, once again, HPV and all of these other diseases. So I am excited about the interprofessional collaborations that are beginning to happen, the conversations that we're having, and it is forums like this that will help our government say that this should happen. We should reimburse dentists for giving flu shots. When our Secretary of Health, when the swine flu epidemic came, they came to dentists and said, can you help us with this? I mean, who's more experienced at giving an injection than the dentist? Can I get a witness? Right? Who's more experienced at that? Lord. So why shouldn't we be? Why shouldn't we screen when we have a patient that comes in that's diabetic? Why shouldn't we? Who's more experienced in drawing blood than dentists? And so, again, I'm excited about interprofessional collaboration. I think at the onset of medicine, we were working together, and somewhere along the way, this division came. But I think if we're going to preserve our children's lives, if they're going to live longer, if we're not going to continue to take backward steps, then we have to collaborate.
Yes.
Thank you. Thank you very much. You know, Dr. Booker, your comments, the first thing that comes to mind is I guess sometimes I forget that the teeth really do tell the tale. You know, the health of our mouths, of our teeth, reveal a lot. And so it's something that I don't always think about. I want to ask the panel, and Dr. Shah, you spoke to this, I think, in your introductory statements, about some of the social determinants of health and some of the structural inequalities that, in terms of poverty, disparities, that impact access and quality. But Dr. Booker, before we move to that, I do want to make sure that I reference Congresswoman Kelly's important work in getting the Action for Dental Health bill passed, the House, and I think it's in Senate now, and how you think that kind of legislation can affect or impact positively some of the concerns that you raised.
Well, I think that it will certainly allow improved access. One of the things I believe that the bill covers is helping to ensure that adults have dental coverage as well. When I graduated from dental school, adults in the state of Maryland had Medicaid coverage. It was limited, but now it's even worse. And so as a pediatric dentist, I do a lot of blood and guts surgery. I go to the operating room. You've probably seen children with stainless steel crowns in their mouth, missing front teeth, children who walk around with a baby bottle and a sip cup, who end up in the operating room that burden you know, our commerce, because those surgeries can run anywhere from $8,000 to $10,000 to $12,000 So I think that we raise a generation of kids who have the benefit of Medicaid coverage while they're children. And then when they become adults, it reverses back because they've seen mommy with missing teeth or with decayed teeth in her mouth. And so now they don't have that Medicaid coverage anymore. And so what do? They turn into their parents. And so I think that that bill will help us tremendously because you cannot not provide care for the parents. Right. I employed a young lady from my community, the community where I was working, and the mother and the parent came in, and the little girl had baby bottle tooth decay. And the receptionist said to me, "Which one are you taking to the operating room?" Ooh. Because both of their teeth looked that bad equally. So you can imagine that child growing up and turning into her mother after she no longer has Medicaid. So I think that's one of the biggest impacts that bill will make. And so we certainly applaud Senator Kelly for the passage of that legislation.
So you mentioned, I know you've practiced in Baltimore,
yes.
Baltimore City, and Dr. Shah, you practice in Southeast. And so I want to ask about, how our young people, our teenagers who are at that stage where they're developing sort of health and wellness habits, if you will, how to eat properly, how to take care of themselves, hygiene, et cetera. How living in depressed environments where resources are absent, or you have, pharmaceutical deserts, you have food deserts. You mentioned one grocery store for serving 70,000 people. What are some of these structural issues that are having the greatest impact on health outcomes for people living in low-income communities? And I'll reference, there was an article recently in the LA Times about a gentleman who just bought the LA Times, Dr. Patrick Soon. And he basically infused funding to revitalize Martin Luther King Hospital in Los Angeles. And so when you were talking earlier, what that came to mind is that there are hospitals in some of these communities who are just struggling. And in some cases, there are just no hospital at all or no grocery store at all. And so as we think about structural issues, structural inequality, how do these things play into outcomes, and how do we begin, more importantly, to address those inequalities?
Thank you. So first, it's unequal, hands down. There are more resources in different parts of DC and different parts of many places in the United States there are in Southeast DC. But even if they were equal, it would still be inequitable, because for equity, we need to do more to level the playing field. So we're not even talking about equity yet. We're just talking about quality. Let's get equal services, and then we need even more investment, even more resources to make it equitable. So specifically regarding the barriers of the kids I see, think about a teenager that comes in my office with asthma, and we have late hours in our clinic, same thing as Northwest DC, but this child is dealing with, if they're coming in the evening, is it safe to walk over to the clinic? They're having that stress in life. They're hungry, they have low access to food, or because there's no grocery stores, there's a lot of corner stores that often have unhealthy foods that are cheap. I think when we think about policy levers of healthy eating, if it costs $2 to buy a 2-liter Coke or $3 to buy or feed a family of 4 at McDonald's, of course you would do that. So we're talking about healthy choices, where I don't even think, and rightfully so, a lot of our teens and young adults aren't to that point yet, because it's the Maslow hierarchy of needs. We need shelter, we need food, we need safety. Now, I don't care about diabetes 20 years from now.
Right.
And that is, as a clinician, that's also what I'm worrying about. I talk about healthy foods, and we have resources. We have Women, Infant, and Children's Program within our clinic. We have a farmer's market that's connected to our clinic that could integrate healthy foods. We have exercise programs as well for dealing with childhood obesity, because kids don't feel safe to exercise outside or play outside. But it goes down to shelter, food, safety, the basics before we get into different long-term health outcomes as well. And this goes along with the idea of toxic stress and adverse childhood experiences, and this is the idea of equity that comes into play, because a child that's born into an environment where there's community violence, where there may be domestic violence or emotional social abuse, it is biologically proven there is a different stress response level for these children as they get older. So they're always in a toxic stress response state, kind of quick to respond, quick to act, and always feeling anxious and stressed out. Adverse childhood experiences not only have mental health outcomes, but also physical health outcomes like diabetes, hypertension, etc. So understanding that and building communities, healthy communities that are able to build children up and make them stronger. I think we are in DC, so I think Frederick Douglass kind of said it best. It's much easier to build strong children than repair broken men. And I think that's the mindset we need from policy, from a clinician to a policy level, building the strong children in every way.
Absolutely. Thank you. Thank you.
One of the things we did in the state of Maryland is we looked at oral health education. We keep talking about education and how to incorporate health into education. And what we found out in the state of Maryland, from K through 12, there were 1.5 hours dedicated to oral health education. 1 hour in second grade and 30 minutes, wherever they choose, between 9 and 12. So we went to the Board of Education. Meanwhile, we had lost, as many of you probably know, in 2008, a 12-year-old died in the 4th richest state in the country to dental disease, Diamante Driver, 12 years old.
I heard about that, yeah.
And he had his head down on the desk. He was already put in an alternative school because he was a behavior management problem. We had a toothache. His teeth hurt. So nonetheless, we go to our state and say, look, we want you to incorporate oral health education in the classroom every year. And they said, listen, we're sorry about the child that died. We now have to have defibrillators in every health suite because we had a 15-year-old that died. We can't afford this. We cannot afford to do it. So we walked out just dejected. The Children's Oral Health Institute led the charge, the Maryland Dental Society, which is a component of the National Dental Association. We had Academy of General Dentistry members there. So I said, let's go back to the drawing board. They don't have time. Let's teach them how to do it. So we taught them, we created a program, the Children's Oral Health Institute created a program called Code Red, the oral health crisis in your classroom. And we show them pictures of how a child looks when they have a toothache, or how they may look or how they may act if they have a toothache. They come to school every day with dry lips, they're not drinking any water, you're singing a fun song, they're not participating. Diamante Driver, they have their head down on the desk. So we taught them how to incorporate a oral health education lesson into their curriculum, a math lesson. How many teeth do you get in a lifetime? Anybody know? 20 plus 32 equals 52, a math lesson. So the booklet teaches all these kind of lessons as to how to incorporate oral health education into your curriculum. We went further. We got legislation passed in our state showing all of our information. 51 million school days are missed because of tooth decay in this country by children. So you can imagine people don't typically run to the dentist. We're the bald-headed stepchild of the profession. How many of you have ever had a toothache? Are you running to the dentist? And that's why you have a toothache, because you didn't get there. And so 51 million school days, how many days does that translate into parents having missed work because they had a toothache? And we talk about, you've seen pictures of children with baby bottle tooth decay. Can you imagine if you've ever had one tooth to ache, how they feel with multiple diseased teeth? It's understandable why that child had his head down on the desk. why he may have been considered a behavior management problem. So that's one of the things that we've done in organized dentistry and others have gotten on board with to create equity. We knew we had to start on the ground to begin to educate our educators about what they were looking at. That's not a behavior management problem. That's a child that's suffering in pain. And so that's one of the things that we started with in organized dentistry in the Children's Oral Health Institute to try to achieve some form of equity in terms of oral health education. We also, again, we talked about earlier the Lessons in the Lunchbox program. And I'll just share this quick story with you is one little boy said, after he got the lunchbox, he wrote us a note and he said, now, he's in the 2nd grade, he said, now I'm not going to lose all of my teeth and have sugar diabetes like my grandmother. And he spelled beaties like the word beets, B-E-T-T-E-S. But the point was, it was a great note. He understood the message. And so, once again, that was incorporating oral health education into a 2nd grade curriculum. He's getting it. So as he grows up each year, he's learning more and more oral health education. It's going to take a while. We've got to do collaborations, interprofessional collaborations, if we're going to achieve a healthier Generation Z.
And I think you also have to bring about prevention, which I haven't heard that word this morning, but it is very important whether you're dealing with an asthmatic, you have to look at some environmental causes as well as the whole situation of around trying to teach them, and I love the education piece because that's very important, but we have to start putting prevention and practicing it. If we don't take a handle of this, and I think your Frederick Douglass comment is really appropriate. It's focusing on how can we prevent some of these diseases, whether it is looking at the environmental causes, the nutritional causes, some of the physical, it's exercising, and the wellness issues that we can put in to prevent those children from having asthmatic attacks or having the decay. If you talk about not getting that baby bottle mouth, not having that sugar in drinking, what do we call it, Mountain Dew, some of those other sugar-filled things as a nutritional thing, but putting in healthier foods with milk and exercising so that in utero you're starting off with educating those mothers of how to raise healthy children and then exposing them to an environment that is focused more on healthy lives so that the children will have healthier outcomes. And I will say, just in terms of reaching our adolescents, we may have to utilize some digital technologies and reaching those adolescents where they are because they don't understand certain health problems that is going to impact them.
I think maybe that's and I know I want to get to our other panelists as well, Ms. Harrington and Ms. Johns, because there's so much here. But I also want to make sure that we leave some time for questions from the audience. And so I'm wondering if you would grant me some forbearance and just allow me to transition us to some Q&A, and I think we can try and circle back, if that's okay. The education piece is obviously vital, and I'll say as a relatively new father, I have a 10-month-old son at home. I'm listening to all of this, just thinking, oh my God, what have I done? You know, I've got to get that bottle out of his mouth right now. But thank you so much, because I think it's so important, and I'll say, you know, the education for parents, for new parents, is vital, you know, because sometimes we just don't know, and I think we all try to do our best, so. Let us transition here, because we have about 15 minutes left, and I want to make sure that we have time to take your questions as it pertains to what we've discussed today. And so I see 2 microphones, and if we can start on this side, since I see a gentleman here, and we'll just sort of volley back and forth. And if you could, in asking your questions, try and direct them to specific panelists, or if it's for the whole panel, that's fine, but thank you.
Hello, my name is Damian Christian. I'm with the Men's Health Network. We run a fatherhood conference with Healthy Start, and I just wanted to ask, well, research shows that a father's involvement in a child's life dramatically improves that child's health and health care and education. do you guys know if there's any tracking of this and what the effects of his involvement in their lives lead to the outcome?
The effects of the father's
Yes,
involvement?
yeah.
Okay, specifically, okay. Does anyone want to,
So in
Ms. Johns?
Caritas, we understand the direct connection between education and health, health literacy, and health outcomes. The Robert Wood Johnson Foundation's Commission to Build a Healthier America report back in 2014 documented this direct link and connection for us. One of the things that we struggled with as a national Medicaid managed care organization was getting our members to be more compliant and adherent with doctor's office visits, medication adherence, et cetera. And we wanted to move ourselves beyond clinical interventions because we just weren't getting those quality improvement scores or outcomes that we were anticipating, let alone reducing the disparities within those improvements. And so in 2014, we launched a social determinant of health initiative to focus specifically on education, looking at our members who do not have a high school equivalency diploma or a GED and providing removing the financial barrier for them to obtain their GED. When we started this program, the medical physician that I was partnering off with only wanted to focus on pregnant women because he wanted to ensure that the value of education was instilled early enough in a woman so that it could become a part of the culture of learning for generations to come, which was great. But half of our population where we were piloting this initiative in Philadelphia was female and the other half was male. And so we were able to successfully expand the program criteria so that we can engage fathers and men in this academic and learning journey. A few years later, once we launched the program in which we offer paid testing and services, paid testing fees to remove the financial barrier for people to get their GEDs, and more importantly than removing that financial barrier, we provide individual coaching and counseling every step of the way of the member identifying which GED program or site that they want to go for classes or take tests, and just to support them with time management, reminding them to go get their health screenings and health checks, et cetera. We've had so many fathers complete that program who are now off to getting jobs that now offer more than an hourly wage and jobs that have benefits so that they can provide that resource to their family and become a positive contributor to society and to their household. We aren't tracking the economic outcomes, if you will, but we are seeing an uptake and an improvement in the men's compliance with the necessary screenings that they may need, or more importantly, just being a more active participant in their health care, which for us is a really big deal.
This side, please.
Hi, Nicole. This question's for you. I wonder what you think about the abuse deterrent formulations of opioids and how that might actually create some part of the solution to the problem of the opioid crisis.
Yeah, abuse deterrent formulations definitely help reduce abuse. That being said, those products can still be taken at dosages that are more than prescribed. So really we focus on three key things when patients are receiving opioids for the first time, to make sure they're taking their medication in the lowest amount that they need for the shortest duration of time, making sure that they're securing that medication in the home, and then they're disposing of unwanted medication when they no longer need it. But abuse deterrents are definitely part of the solution. It's just making sure that we're looking at that whole holistic picture, if that makes sense.
Excellent. And I should say, from the Washington, D.C. area, we're looking at the pharmacogenomics of some of the opioids and the impact that that has. And we have a program here through one of our medical home providers that's looking at that in our community.
Excellent. Yes, ma'am.
Good morning. Thank you to the panel for this important and interesting discussion. My name's Amy Moyer, and I work for Kaiser Permanente as their program manager for community health, DC and suburban Maryland. And one of the questions that I wanted to ask the panelists is, in my previous experience, I worked in Palm Beach County for the Children's Services Council of Palm Beach County, and it's a government agency that's funded by property taxes. Their budget is $100 million, and 80% of their budget goes into early intervention and prevention throughout the county, regardless of your income. Not a lot of states have children's services councils that focus on early intervention and prevention. And so my other quick thing is that you talked a lot about collaboration, and one of the things that they did is a collective impact, and it was called Birth to 22 United for Brighter Futures. And because it is partially a government agency, they have all their information on the website, but they pretty much worked with the school district, the health department, community agencies to figure out where their funding starts and where it stops, and how they can have a coordinated system of care to address everything that you mentioned. But even that, they still had issues with advocacy and legislation. So my question to you is, after collaboration and pulling your resources together, do any of you have any involvement in advocacy or legislative agendas to help move this forward?
Well, certainly the National Action Plan has that. We're dealing with national, state, and local legislators to affect the policies that are going to be there. And then we have our faith-based organization as well as social organizations, getting those community leaders to then take that to the community. They're our advocates, as well as the National Medical Association has a large advocacy component. So yes, we recognize that both components are equally important in getting the word out.
I think it was a great question, and we certainly look to our medical colleagues for support. And I think you said a key word, it is legislation if we're going to achieve it, coming together, because we don't want barriers like what was told to us. Well, you can't diagnose, so we're not going to pay for the Schneider test for us to screen this child for lead paint poisoning. So he sits in another grade, fourth grade, and then he turns into Freddie Gray because he was never screened for lead paint poisoning, and he has these shortcomings in terms of his ability to learn, to be able to pursue a job. So I think that we certainly will look to our medical colleagues, because how do we come together and how do we get the respect or get our policymakers to understand that it has to be a collaborative effort.
Okay, we have about 10 minutes, a little under 10 minutes left, so we want to try to get to these questions. Over here on the left.
Thank you all very much. This is a very interesting discussion. My question is for Dr. Shah. So my name is Faye Knowles. I'm a pediatrician at a FQHC in the state of Alabama. Recent statistics show that about 1 in 3 children are overweight or obese. In my population, I think probably the statistic is higher than that. There are programs, like you mentioned, the WIC and exercise programs, but I find it very challenging when these obese children come in and their parents and other family members that they come with are obese themselves. I was wondering, in your practice, how do you address this, or if there are any programs that evaluate the family as a whole instead of just the individual child?
Thank you for your question. It's a multi-factor. Childhood obesity is an epidemic, and it has multifactorial origins, specifically around family eating habits as well. Parents are obese, they have certain eating habits. The children are obese as well. Specifically for your question regarding programs, at Children's National we have something called the Ideal Clinic. So it's this clinic in which it is about 2 hours of not only education, nutritional and exercise counseling, but also a psychologist, because things such as binge eating behavior has underlying origins, again, going back to stress, going back to toxic stress and binge eating behaviors as well. But again, I think it's even more widespread than that. There are multiple other factors outside of even food. So there's food access, but again, going back to that idea of a McDonald's costing much less, if you are poor, you have unhealthy options anyway. So there are things that we could do in clinic. There's programs that work, there's programs that sometimes don't work, but to really affect the epidemic, going back to the previous answer about legislation, I think this is where it could actually make a difference, is talking about how do we improve access to healthy foods and healthy exercise, and how do we reduce or have unhealthy foods less access. Again, the basic question is, if a 2-liter bottle of soda in McDonald's costs $5, and if healthy food costs $20, we could have as many programs as we want, but just that economic factor will not change. And this is where I think the people in this room and everyone thinking about legislation regarding that, because they, what's the thing we could do to improve the health of our nation? Heart disease, diabetes, hypertension, these are the leading causes of morbidity and mortality in our nation. The solution has nothing to do with healthcare access, in my view. It could be all to do with better regulation and taxation regarding our food policy and agriculture. So in your clinic, I think what we do is we just keep on trying and keep on finding access and priorities.
I think one of the things that you could do is to have the children or the families to start to grow some of their own fruits and vegetables. Go back to the old time thing where you make a little garden and you grow some of those things. You do demonstrations in terms of teaching them how to cook with those foods and how to increase that palate so that they want to eat kale versus the McDonald's. So you really want to do an educational program about nutritious food so that preparation and getting the children to help their parents to prepare new foods that they have not been introduced to, and building up that whole thing to change that environment.
Okay, we're really just about out of time, so I want to get the gentleman here, and then I'm going to ask the two brilliant, beautiful sisters. Okay. I was going to say, if you all can combine your question, get creative. You can combine your question into one. We can get it in, but we're on the clock. So go. All right, go ahead, brother.
Good morning. My name is Jean Bonhomme. I'm a public health preventive medicine physician working with the Men's Health Network and the National Black Men's Health Network. What I wanted to say is that dentistry may indeed be the bald-headed stepchild of healthcare, but it has a model that I think that all of medicine should be looking at, because what they do, ideally, is to get people in every 6 months to examine whether they are ill or not. Now, my own family history, both my parents by my age had lost all their top teeth. The only thing I've ever lost is 2 wisdom teeth, and that was only last year. So the point is that by following preventive care, being checked out even when I'm not feeling bad, our medical model is go to the doctor when you feel sick.
Right.
By the time you feel something, you may be in an advanced state of disease sometime, or much more needs to be done about it. I think that medicine needs to look at dentistry and what they're doing, because I think that that's where we can really start cutting costs, preventing advanced diseases, and also nipping things in the bud. So thank you very much.
Right. Thank you for that comment. In fact, the hallmark of the profession of dental medicine is prevention. And so thank you for those comments. And that was my point exactly. Why shouldn't we be doing the lead paint poisoning screening? Whose spit is it? We see the spit every day, so it should be inter-professional collaboration. And to our physician's point is the child is obese, the parents are obese. The same in dentistry. The child has early childhood caries. Can you imagine the caries the parent has? And so that mother or that father more than likely inoculated their own child. They lick the nipple. They lick the pacifier. They blow the food. And so, well, I mean, your point is well taken. Thank you, absolutely. Because we are doctors.
I speak really quickly. I'm from Philadelphia. So my question is for maybe Dr. Shah and Ms. Harrington around what are you seeing around trends for inhalers that are more involving addressing equity? You thinking about the environment. I went to a Kaiser Permanente tour, and they had this inhaler that maybe is really expensive. That's why schools haven't adopted it. I don't know. It's not widespread. But if there was a partnership or an investment or interest in addressing equity from like a CVS, we could have those in schools where they show which environment the student is in when they are using the inhaler. It tracks a lot of data from what the tour provided or the guide provided. So where are you with those types of tangible things that can actually combine environmental triggers and the symptoms, which is what you see manifest on the surface after it's already kind of an issue?
So I shall be obedient and add my question to hers. That's what I was told to do. So my question simply was, when all of this is said and done, the community, the whole community is what's important. Getting the collaboration with the interprofessional groups and the community. And how do we actually raise up the community when they're doing a good job? I'm Golda Downer from Howard University.
All right, thank you.
Regarding the technology aspect, really quickly, healthcare isn't to a place that other industries are in integrating technology, and I think we're getting there. Propeller Health out of Silicon Valley is a perfect example of this inhaler technology company that uses inhaler GPS locations to determine areas in cities in which there's hot spots of poor environmental allergens based on how often you use it. I think we need to harness this technology that's used in other sectors and really do a lot with childhood asthma and also in healthcare. And the way to do that, to parlay with the next question, is you have to have community, not engagement, empowerment, and they have to have a seat at the table.
Absolutely.
You know, we're not, it's a collaborative effort, but it's almost a leading effort on their behalf, and we're just the civil servants working for them.
Awesome. I think that might be a great place to stop.
I got a little announcement. That's not a
question. We got to cut it. We got to cut it. But I'm going to close the panel, and then afterwards, if you want to come up.
No, it's an announcement for the whole group. So
what's that? Oh, announcement.
It's a very short announcement. Since the opioid epidemic was mentioned, and Ms. Harrington mentioned securing your drugs and getting rid of your drugs, the DEA is sponsoring its annual Drug Take Back Day on April the 28th.
Okay.
So you can all go back home, look to your drug cabinets, and dispose of all the things that are not necessary and that could be cause of some child or somebody stealing that and contributing to the opioid problem. Thank you.
April 28th. All right, you have it. Please give another round of applause for our panelists. And our sponsors, thank you so much. This has been a wonderful conversation. I'm sure our panelists will be here a little bit after the panel if you have a burning question you didn't get a chance to ask. But we thank you for your questions and for your participation.